Hello, my name is Jen Marino. I'm a clinical specialist with Roche Diagnostics, and this presentation will be on the implementation of high-sensitive troponin T. Pineville Community Hospital is using the contemporary troponin T and will be converting to the high-sensitive troponin T sometime before the end of this year. Please look for communication on the go-live date. In this presentation, I will discuss what to expect when implementing high-sensitive troponin T, how is it different from your current troponin T, and then I will share the algorithm that will be used. So first, when you implement a high-sensitive troponin, the clinical benefits is you'll be able to identify more myocardial infarctions and identify them earlier because of the enhanced sensitivity. And with the enhanced sensitivity, you will identify more myocardial injury as well. So this is a model that is from the fourth universal definition of myocardial infarction. The consensus group came out with how to differentiate, is this chronic myocardial injury, acute myocardial injury, or acute myocardial infarction. The key is to do serial troponins. If you notice that your troponin level is stable, there's not a significant change, this reflects more of a chronic myocardial injury process. So, for example, patients with chronic renal disease tend to have chronic elevations of troponin. And so this is where the pathway will be very different from somebody who doesn't have a significant troponin change. On the other hand, if you do notice a significant change between the serial troponins, now it could be a rising troponin or it could be a falling troponin. They have the same clinical significance. If there is no presence of acute ischemia, so this is looking beyond the troponin, what does the EKG show? What are their symptoms? And if there's no acute ischemia, you have acute myocardial injury. And some examples include myocarditis, acute heart failure, sepsis, critical illness, etc. But if you have a troponin that's rising or falling that has a significant change, and there is presence of acute ischemia, so maybe EKG changes, chest pain, nausea, vomiting, etc., then you have an acute MI. And the provider will determine if this is more of a type 1 MI, which is that plaque rupture, atherosclerosis, or is this more of a type 2 MI, which is more of a supply and demand imbalance? Now, when you implement high-sensitive troponin T, because of the enhanced sensitivity, and because you're going to identify more MIs and identify them earlier, you are also going to identify more myocardial injury. So you're going to see more elevated troponins. These are not false positives, but they may be positive for myocardial injury that may not be an MI. And when I show you the algorithm, that's going to help differentiate those patients. One of the major changes is the units of measurement are going to change from nanograms per milliliter or decimal points to nanograms per liter or whole numbers. So the other thing is the measuring range with your troponin T started at 0.01. You now can measure all the way down to 6 nanograms per liter on the high-sensitive troponin T. So you're now capturing patients in this gray bar that were not detectable with the contemporary troponin T. And some of your patients in this gray bar may be having an MI and or myocardial injury. But just to give you an idea of what your current troponin T values are and what the high-sensitive troponin T values are, a 0.01, and again, this is nanograms per milliliter, equates to about 30, which is nanograms per liter. A 0.03 equates to about 52. A 0.1 equates to about 100, and a 0.3 equates to about 300. So again, it's not just moving the decimal points. There is an equation, but it's pretty intricate. But anyway, this is what to expect with moving to a high-sensitive troponin. The measuring range of high-sensitive troponin T measures from 6 to 10,000 nanograms per liter. And as the values increase, so does the severity of the clinical condition. So for patients that have values below the cutoff, there's a high negative predictive value that it is not myocardial infarction. But for values that are at or above the cutoff, again, these may be patients that are having an MI, or they may have some sort of myocardial injury, whether it's acute or chronic. Here are some key points to consider. You will be using the algorithm that was adopted by Baptist Health in Kentucky. And so the cutoffs will be sex-specific cutoffs. So for females, anything less than 14 nanograms per liter is normal. And for males, less than 22 nanograms per liter is normal. You will be using the heart score. The serial testing will be a 0-hour, 2-hour draw. And now what's different is you'll be using the delta, which is just the difference between the serial draws. So for example, if your baseline troponin is 25 and your 2-hour troponin is 35, you have a rising troponin. The delta is merely 35 minus 25, and here's your delta of 10. And what's a critical value is a value greater than or equal to 53 nanograms per liter, and that will be called. So here's the algorithm that will be used. And here's kind of a caveat where in the emergency department, you can do a single troponin if their chest pain onset was greater than or equal to 3 hours, their heart score is between 0 and 3, and their initial troponin is undetectable, so less than 6 nanograms per liter. In this case, you can rule out these patients with confidence. Otherwise, you'll do your baseline troponin, and in the green, if it's negative based on the sex cutoff. And then next, the question is, was the onset of chest pain greater than 3 hours? And was the high sensitive troponin T less than 6? If the answer is yes, and their heart score is low, then you can discharge that patient. Otherwise, if they had chest pain onset that was less than 3 hours, you would have to draw their troponin at 2 hours. And then the delta, what's going to be called significant, is a change greater than or equal to 4 nanograms per liter. If the answer is yes, then consider cardiology guidance with a possible admission or observation. If the delta at 2 hours was less than 4, then look at what their heart score is. If the heart score is less than or equal to 3, you can discharge the patient. Otherwise, if it's above 3, then shared decision making, whether that's observation, further diagnostics, or discharge with close follow-up. If the baseline troponin is greater than or equal to 53, then you admit or consult the appropriate service. And again, this equates to about a 0.03. Otherwise, if the patient is between the 14 or 22, depending on the sex of the patient, and between that cutoff up to 52, then you will need to follow the patient a little bit more closely and get a 2-hour troponin. And again, depending on what the delta is, then that's how you'll disposition the patient. So again, the target date is still being determined, but it will happen sometime before the end of this year. And please look for communication. Thank you very much for your time.